Good evening, good afternoon, good morning, everyone from wherever you are. I'm just watching as you all signed up that we literally have participants from all over the world. So thank you very much for joining us in this special webinar on monkeypox that the IAS has brought to you at, I must say, a very short notice. So we're very, very grateful to our speakers, Dr. Meg Doherty, Dr. Marina Klein, Dr. Chloe Okin, and also Dr. Coletso for really saying yes to us in just a few days ago when we decided to put this webinar together. The aim for this is, of course, to provide you with the latest information on the epidemiology of the monkeypox in non-endemic countries and discuss prevention options, as well as update you on clinical presentation and treatment. And we hope to also hear current research networks and, importantly, perspectives from the community to bring focus to the best ways to reach those most impacted to date. And of course, with the aim to prevent a rapid spread of the virus during a time when countries are opening up once again following the COVID pandemic and large gatherings are starting to take place once again. So, as you all sign up, I'm going to hand over to Joan, who's going to brief you on some housekeeping rules, and then we'll get going with the webinar.
So, hello, everybody. Thank you very much for joining. So as you can see, please note that since we have a lot of participants who are currently muted, and we have time for the presentation, after the presentation, for a Q&A session. So you may send any question that you may have for our speakers about today's topic in the Q&A box at any time. If your question is specific to any speakers, please kindly indicate the name of the speaker when you're typing the question. That will help us to address the question more precisely. You will also notice that there's a thumbs up symbol when someone will ask a question in the Q&A box. If you have a similar question, or if you think this is a relevant question, please click on this thumbs up, so that will help us to prioritize the questions. If you're having any issues with Zoom, you can find additional guidance provided in the chat box. You will see a message explaining where you can go. And in the chat box, please feel free to also let us know your name and organization and which country you are from. Thank you for connecting. We love seeing interactions and comments in the chat. Before I'll pass on back to Adiba to introduce our first speaker, we would like to thank our donor, Viv Healthcare, to make this important session possible. Adiba, please go ahead.
Thank you. So we've got a lot to cover. So I'm just going to go right in by introducing our first speaker, who I think most of you in the HIV will probably know very well already, and that's Dr. Meg Doherty, who's the Director of Global HIV, Hepatitis, and STIs at the World Health Organization. Meg, I think you won't mind if I say, please dive right in, if I don't read the rest of your bio, because I think everyone here are very familiar with Meg, and we're very, very grateful that you said yes to us at such a short notice. Go ahead.
Thank you very much, Adiba, and I'm really pleased to be able to be here with you. And I'm going to share slides because it's not often that somebody from the HIV department or HIV STI department is actually working on an outbreak. But because of the nature of the monkeypox outbreak, we are involved. And so I'm pleased to be able to present on behalf of the WHO emergencies team. There are many people behind the scenes here, the latest epidemiology and what they're doing and we all are doing for response. And I thought I would also touch a bit upon what are the implications for people living with HIV and or STIs, because that's so important to us. So you'll be aware that if you're watching the news, that monkeypox is a viral zoonotic disease. It's similar in genus to the variola virus or the smallpox virus, which had been eradicated and confirmed eradicated by the WHO in 1980. But this monkeypox, rather than the smallpox, has been endemic in more than 9 African countries. And there are 2 main strains, one that is typically found in the Congo clade, which is more severe in the Democratic Republic of Congo, and less severe, the West African clade, which has been predominantly found in Nigeria and other countries on the coast. Currently, in the multi-country outbreak, we've only seen the West African clade has been identified. The reservoir host is still unknown, although rodents are incidental hosts and may play a part in transmission, typically through hunting, preparation, and consumption of meat or game. I think what's so important for WHO is that, you know, it's not just because it's in non-endemic countries or in where we're seeing it in the West now that WHO has woken up to the problem of monkeypox. WHO has been following and been involved in identifying and training and surveillance and response to monkeypox in the endemic countries for years. And there have been reported cases over this past year through the surveillance system. And WHO is in the process and does do work to support the laboratory systems, surveillance, readiness to response, and also providing technical guidance, clinical care information. And we'll be able to, I'll share some of these links later, because it is important that we note that this has been going on for a long time in other parts of the world. But we have raised our concerns about this atypical or unusual outbreak in non-endemic countries. And what we've seen as of June 1st is here somewhere near over 600 cases, with some probable cases coming out, much of it focused in around the European nations. But again, we also have endemic monkeypox. So what are we seeing in the non-endemic countries? Since the 13th of May, it's been reported to WHO from 26 member states across 4 regions of WHO. So this is considered a global outbreak. Public health investigations continue to are ongoing around case finding, contact tracing, laboratory investigation, clinical management, and case isolation. Not all the factors around this outbreak are known, although initial cases we're seeing through presentation to the sexual health services among men who have sex with men, but it's not exclusive. Some of the early cases was in a family as well as in other contexts, and not simply only men who have sex with men. And so we're doing quite a bit of outreach, especially from our department, because the concern and the risk about stigmatization, using poor language, and for example, early on, we would see some indications that people were very concerned about another disease linked to men who have sex with men, gay or bisexual men. So we're doing quite a bit of work in that area, and it will be good to hear also from our colleague Kaletso this today, because we've been having some conversation with him as well around these issues. And it's currently right now, the scope is that there are many sporadic cases, that there is human-to-human transmission going on, but this may have been circulating for quite a while unrecognized for several weeks or months is the sense of this epidemic. This gives you the epidemic curve where most of the cases are happening in Europe, some case in green color, and in Latin America, and in a few other parts of the world. Again, it would be important to also share that we are monitoring since January the cases that are happening in Africa. And here we have up to 1,400 cumulative cases. And here are some of them quite severe, especially in the Democratic Republic of Congo, with a total of 66 deaths since the start of the year. But so just to say, we want to put this in the context, currently with the non-endemic outbreak, we have not seen any deaths yet thus far. We're also starting to see reports coming out from countries who are doing their own individual epidemiologic reviews. This is a paper that came out just yesterday looking at the Portugal outbreak, where they're looking at contact tracing. Do people have travel? Do they have information of have they been in a certain venue. And I think what's also, we'll hear from our colleagues, is what is the clinical presentation, where often it could be just rash and lymphadenopathy, not necessarily always fever first, but also the vesicles that may be in many parts of the place, but also in the genital area as well. So this is also important as we start to get a better understanding of what's happening with this outbreak. We're also seeing other papers that are coming out, not yet, this is not WHO work, but what would be the impact if you wanted to have a containment effort around this outbreak, where one would include both treatment and vaccination. And certainly having an approach where vaccination of contacts or contacts of contacts, like done with Ebola, might be something that could be addressed. And certainly the WHO is looking into this, but has not yet made any recommendations around this. So these kinds of modeling exercises are really helpful to inform how we go forward with the response. I just want to outline for my colleagues in the emergencies team about what actions have been happening. So since May the 7th, there has been, WHO is informed, and since that they have put out an event information site or an EIS site, and for WHO in emergency terms, there's a disease outbreak news, which gives you information about the case, the control, how to identify this, and that gets updated regularly. Question and answers have been put online for general public. Many meetings and many advice happening, as well as different tools put out around laboratory testing, as well as surveillance. And right now there's an ongoing meeting about research and development. So there's quite a bit of information and work that's happening simultaneously. If you go to the WHO website, you'll see a link to all of this information, and you can publicly go and listen to the monkeypox research. Countries and interested persons can download surveillance and case investigation and contact tracing guidance, laboratory guidance, as well as very soon there will be the clinical management guidance. So I recommend you to take a look at all the good work that's coming out. Our department, in particular, the HIV/STI department, have been working on risk communication with our colleagues in emergencies, and really wanting to ensure that we put out a messaging around non-stigmatization, because anyone can pass on monkeypox regardless of their sexual activity. And what we have known right now with this outbreak, that it has been happening through sexual contact. Very difficult to say whether or not this is a new sexually transmitted infection until some of those research and studies are done. But on the other hand, we know that monkeypox is transmitted through skin to skin, face to face. And if somebody has an open sore to sore. So when one wants to protect oneself from protecting yourself and protecting others, the messages have really been around isolate at home if a person has lesions, talk to a healthcare provider, avoid skin to skin or face to face contact, including sexual contacts with anybody who has symptoms. Clean your hands, objects, surfaces that have been touched regularly, and including wearing a mask if you're in close contact with somebody with symptoms. And we're really trying to get to the bottom that we would like to be able to have people empowered to know what the signs and symptoms are, but also not to have populations stigmatizing those who may be infected. So part of that, what WHO does also is put out information for healthcare workers, because we have to give information to the public, but also give information to healthcare workers. And this set of slides that I'm showing briefly is part of a series of slides that gets the most important information out. So signs and symptoms, self-limiting, that the symptoms last about 2 to 4 weeks, can be in children and pregnant women, and those with immune suppression could be having worse symptoms. Incubation 6 to 13 days. I spoke a bit about the kinds of symptoms people come in with: headache, muscle aches, backache, skin lesions, swollen lymph nodes. But it's important to know that these rash evolve, and people haven't seen smallpox. So this is something where people haven't seen this, and they're larger than chickenpox. So it's something that a good clinician or healthcare worker is going to need to keep a high suspicion, and one might say, but not so much suspicion, but a high educated view on rashes that are coming in, because some of these rashes could also look like syphilis and or herpes, which are STIs. And so those are an important thing that has to be looked at, discussed, get a good history, and ruled out between the healthcare worker and the person presenting with any kind of symptoms. And I think we're going to jump through this because you may hear about this from the other speakers. But what is important is early detection and isolation for those who have open lesions. Just like with chickenpox, your child would go home and be at home during this period of time. And since lesions can be a source of sharing, the people who do have any kind of rash or vesicular lesions should be trying to take care that they don't spread it to others. Diagnosing, right now we're using PCR and from samples, but I think ideally, and this is some of the research and development questions that are coming up, that we would love to have a more rapid test so that there can be more rapid diagnosis. And clinical care is mostly supportive. There are some treatments out there, antivirals like tecovirimat, but these are not widely available right now. And that's again another area for research and development to ensure that we can get treatments available if needed, and more newer treatments for longer term consequences. There will be some questions about vaccination. I may not be the best person to answer all of these. These slides come from my colleagues, but the vaccination of the smallpox vaccination is approximately 85% effective against preventing monkeypox. But there are newer vaccinations. And I think right now that's one of the big areas of how to work on vaccination and ensure that those people who really need, the frontline workers, healthcare workers, those in the laboratory, and those who are contacts or recent contacts would have access to the vaccination. This is not about getting vaccination to the entire world, and it's not about COVID. It's very different than that. And I think I will just be happy to take questions, but also refer you to my colleagues in emergencies who would be much better placed to answer some of these questions. Lastly, I want to finish off by, I think for anybody working in HIV and STIs, we're always wondering about, are those who are immunosuppressed or people living with HIV, are they at greater risk? Currently, right now, there's very limited data. There's very small studies that have come out of Nigeria where those who are untreated for HIV may be at greater risk for death, in very tiny study, hard to say. And the prevalence of monkeypox was higher than the background prevalence. Again, this is ecological data in Nigeria. So this is an area where we really have to get more information. But certainly there is a sense that if somebody is immunosuppressed, and not all people living with HIV are, since they're on their antiretrovirals, that they may have a more prolonged or a more severe case. And recognize that currently right now, these cases are not, that we're seeing in this non-endemic outbreak, have not been as severe as some of the cases that have been seen in Africa, but you'll hear about that later. But this concern or this desire to ensure that people are aware of monkeypox have really led both the BIVA and the EACs to come out with some statements about HIV and monkeypox, and ensuring that, you know, it's a great opportunity to reinforce that people living with HIV should be on their treatment if they haven't been tested for HIV, to get a test for HIV and access antiretrovirals very soon. Now, this just came out last night. I mean, I think we're going to see many, many case studies coming out very soon, where it is going to be a clinical a desire to get more information about what the clinical presentation looks like, but also to ensure that there could be multiple infections happening at the same time in a person with monkeypox. That could be syphilis, it could be HIV, it could be gonorrhea. So we have, as those of us working in the HIV field, one needs to be able to ensure that all of these different infections are kept in the differential, and then also addressed in the response and the care and treatment. And I think early on too, we didn't have a lot of pictures other than very small children from Africa with very severe monkeypox. And here we're starting to now see some of the different kinds of presentations. And I think as more pictures become available, it's important so people are aware of what it looks like now in this outbreak. Other things that WHO are doing is really following the infodemic information and trying to really help dispel any of the negative and or false narratives that are occurring. And part of what we do is we put out risk communications, videos, and also interactions and interviews. There's been a number of Facebook Lives with my colleague Andy Seal, really talking about what this means for people, and really using to the best of our ability to ensure that community and that we use language that's non-stigmatizing at all times. So I welcome you to take a look at our website for some of these documents. So WHO key priorities are to stop the outbreak, so to raise awareness as we're doing now, detect the cases early on, stop transmission by keeping oneself safe and others safe, or preventing that onward transmission through infection control, contact tracing, self-isolation. For those of you who are involved in surveillance, there's case reporting forms that should be used. We want to have effective communication, and we want to look at a risk-based strategies because this is definitely not COVID at this point in time. So we want to be measured in our communication and looking for global coordination. And I think that coordination and collaboration really helped in COVID, made sure that if there are vaccine therapeutics and diagnostics, that they're shared in the best way possible to address the outbreak and to accelerate research. And there are many unknowns. Why have transmission patterns changed right now? How much unrecognized infection has been going on? We're going to start to see the genetic sequences and genomics coming out very soon to show if there's any changes. Are there any differences in severity or risks of the disease? And one question that has come to me multiple times, which we are unaware of the answer, if a person has monkeypox, will they be able to get monkeypox again? And I think that immunity from previous infection is just unknown at this time. And we want to be able to work on interventions that impact outcomes and improve outcomes for all people. So we hope to respond quickly. We want to be able to work across both the endemic and non-endemic contexts. We're taking lessons learned from smallpox, and we're looking forward to hearing more from you about the research and the work and the communication that you're all doing. Here are some resources, and I pass back to you, Adiba. Thank you very much.
Thank you, Meg, for that great overview of the epidemiology of monkeypox for both the non-endemic and endemic from countries, as well as an overview of the clinical presentation and what next. I'm seeing a lot of questions come through, and in fact, we've had a whole lot of questions come through even before the webinar started. What we're going to do is have all the panelists present, and then in the last 20 minutes, and I'm unfortunately we're not going to be able to cover all the questions, but we'll do our best. And try and cover the most critical questions as best as we can. Okay, and moving along to expand on the clinical presentation of the patients presenting with monkeypox. We have Marina Klein from McGill University. Marina was a former Governing Council member and is currently Professor of Medicine and Research Director of the Infectious Diseases and Chronic Viral Service at McGill in Canada. As you know, apart from Europe, Quebec has also had a number of cases, and Marina is going to share with us some overview of the clinical presentations from the Quebec outbreak as well as from the other countries. Over to you, Marina.
Thanks so much, Adiba, and thanks everyone for joining today. It's really fantastic seeing all the names and countries that are represented here. I'm going to try to address in a short time some of the particular clinical presentations of monkeypox that we've been observing outside of endemic areas and highlight some of the things that might be different than what we've seen reported previously. These are my disclosures. So just to start, I'd just like to say, first of all, I want to thank the patients who've consented to share their histories and photos for this presentation. It's really been very heartwarming to see how much they felt that this was important as we're seeking in real time as much information as possible about this new epidemic and how much they really felt that this was something that they wished to give. And I think that just stands to the fact, and we're going to talk about this later, how important it is really to collaborate with the communities that are being currently affected by this outbreak and work with them to do so in the best way possible. I also need to thank my colleagues, Luke Harrison, who's an infectious disease fellow at our group, who's been really pulling together all these cases, and Safa Barkadi, who's been a tropical medicine specialist, who's been really leading the way for us. So just to review, I think Megan touched on some of these, but I just want to highlight some of the classical features of endemic monkeypox that have been described. Really a clinical syndrome that follows a relatively common pathway, at least as described, starting with fever and systemic symptoms, then the rash, and you saw some of those pictures, that is quite characteristic, and is also characterized by prominent lymphadenopathy, which really differentiates itself from, for example, varicella chickenpox infections. The rash is said to be usually as a maculopapular rash that proceeds to these pustules that can be quite large and painful, and then they become ulcerative and form what looks more like what we've seen in many images as these sort of pox-like lesions. And they typically start on the face and then spread on the body, and they can be found on the hands and soles, as well as in the mouth. Monkeypox can be quite serious in some people, and complications that have been reported include pneumonitis, encephalitis, keratitis that can be sight-threatening, and secondary bacterial infections. And in some areas, the reported mortality rates can be quite high. And as mentioned by Megan, this seems to be differentiated by the type of clade or variant that's been found, where those outbreaks in the Congo Basin have been associated with higher mortality and lower rates of mortality in the variant found in West Africa, which is the variant that we're currently dealing with in the worldwide outbreak. What are the risk factors for these more severe outcomes? Two that have come out principally have been younger age, that's age under 8 years old, so in children, and people who are infected with HIV. Not necessarily much details on that with respect to whether they're untreated or treated and what stage of HIV infection. One would assume that this is more immunocompromised people, but we don't have a lot of data. Person-to-person transmission does occur, it's well documented, but it's never been felt to be very efficient. So typically these are household settings or close contacts and spread through either droplets, so not as far as we know aerosolized, droplet spread because it is carried in the respiratory secretions, and direct contact with infectious lesions. And we'll talk a little bit more later about whether there's a component of sexual transmission and what could that be due to. Just at the beginning of when we were starting to recognize that this may be taking a new phase, there was this report that many of you may now have read that appeared in the Lancet on May 24th, which described the clinical features and management of human monkeypox among 7 cases that had occurred in the United Kingdom between August 2018 and September 2021. 4 of these cases actually were imported and related to recent travel to Nigeria. 3 cases were acquired within the UK, one which was a nosocomial transmission to a healthcare worker who was not protected with PPE, and 2 via household transmission from an imported case to their child or to their spouse. And there you can see some of the images. I think these typical sort of more pustular lesions on the hands and soles of the feet, some of which ulcerate. And then they interestingly described an abscess, which was quite deep, drained, and was DNA positive for monkeypox and negative for any bacterial infection, suggesting that, and this is the first reported case of this sort of deep tissue complication. One of the, although the case series is relatively small, I think it was extraordinarily interesting because all the patients were hospitalized for isolation reasons in a high protected unit, and they underwent repeated sampling over time of various different secretions, and really gives us a picture, a clinical picture of perhaps where the virus is replicating and may potentially be spread from. So it's small, I don't, if you have a small screen, but in red is blood, in green is upper respiratory tract secretions, and in yellow is urine. And just to say that you can see that viremia is present in all, though the copy number relatively high, so not high levels of virus necessarily, but respiratory secretions were shown to be frequently positive, and that there was prolonged DNA shedding in the respiratory swabs even after the resolution of rash. So this dotted line indicates a period of rash. These patients, as I mentioned, were hospitalized. Some of them were kept in hospital for prolonged periods of time due to isolation because of the prolonged shedding, and this was really for infection control reasons. But one of the patients was actually hospitalized for almost 39 days. So this is a very long course. I won't go into this too much. These little arrows indicate treatment episodes, and I'll talk a little bit more about that at the end. So what about the current outbreak? Well, now we're seeing that this is occurring among people with no travel history to endemic regions, although there has been reported travel between and within Europe and between countries and Europe and now within North America, who are reporting cases. Thus far, although there's been no comprehensive report summarizing all the cases to date, more than 95% appear to be male, most of whom are men who have sex with men, or other gay and bisexual men who have sex with men. And typically in the younger age group, between 20 and 49 years of age. Just to note that smallpox vaccination ended in most developed countries in early 1970s. In Canada, that was 1972. And so this would represent an age group who would have no prior potential immunity to smallpox. Here I illustrate the confirmed cases in Montreal. So none on early May, and rapidly increasing to 52 confirmed cases as of yesterday, although we know there's about more than 70 under investigation at the moment. So I'm going to present a series of cases very rapidly just to give you a flavor for what we're seeing, because this has been something a lot of clinicians have been asking for, and I think it helps us kind of understand how we need to perhaps have a very high clinical index of suspicion going forward so that we don't miss potential cases. So the first case is a 32-year-old man who is a gay and bisexual man who has sex with men. HIV positive. He's well controlled on a combination of Biktarvy, emtricitabine, and tenofovir alafenamide. CD4 cell count is high and an undetectable viral load. He's been sexually active with multiple unprotected male partners, and one of these partners was actually recently hospitalized in the United States with a diagnosis of monkeypox after traveling to Montreal. So there was an epidemiologic link, either in which direction the infection occurred, we don't know. So he presented on May the 10th. So remembering that we had no cases reported in Montreal at this period, he developed symptoms of proctitis, very painful inflammation, and didn't present for care at that time. then was noted on May 13th to experience this onset of rash, which I have pictured below, and you can see this typical lesion that he had. Very few of them scattered throughout on his core and arm. And then only presented for care on May 17th, where he continued to have ongoing rectal pain, but was also complaining of sore throat. The rash continued to progress, and now you can see that he was developing these lesions, and these are quite classic, I think, the ones we've been seeing, sort of heaped up with a central ulceration and a dip that looks quite different from what you might see, for example, from varicella. And then he was seen at a clinic when he had this rectal pain and had an STI screen and was diagnosed with rectal gonorrhea. We saw him at our clinic the following day as the rash was progressing. And at that time, blood samples were taken. The roof of this lesion was sent for swabs as well as dry swabs of other lesions. And these were both PCR positive for monkeypox DNA at our National Microbiology Laboratory. The second case, also a young male, no significant past medical history, not HIV positive, not on PrEP. So I think this is also an opportunity to think about other interventions that we can discuss with patients when they present in this way. Sexually active also with multiple unprotected male partners at a sauna in Montreal, and no travel. He developed as his first symptom a painful penile papule, which progressed a day later to painful inguinal lymph nodes, and this lesion on the penis became more pustular, and then he developed some lesions on his trunk. The first case, I should alert you, had never had any systemic symptoms, no fever of any kind. This case, however, on May the 12th, develops generalized malaise, fever, and chills, and then is presents to an emergency room where he's treated with penicillin and doxycycline for presumed sexually transmitted infections. And no sampling was done at that time, recognizing that we had yet to have any cases in Montreal when this happened. On May 19th, he was seen at our center, by which time his lesions had largely improved. All his systemic symptoms were gone, but he had this residual painful genital ulcer, and this was swabbed and was positive. Unfortunately, I don't have pictures that I can share with you, but these were very multiple lesions on the shaft of the penis, and very heaped up and looking like the one on the face that I showed you before. The third case is an older, slightly older male, so 50, no history of smallpox vaccine. He has been HIV positive for 20 years and well controlled on dolutegravir lamivudine currently with a high CD4 and undetectable viral load. Also sexually active, and had visited a bathhouse around the 4th or 5th of May and had no travel. On May 9th, I actually saw him as a patient of mine in the clinic. He had no symptoms at that time, but because he'd had these recent sexual exposures, he requested STI screening, and there was nothing on exam. On May 15th, so we're talking about a week later, he starts with fever and malaise, and then subsequently develops this painful perianal lesion, which you can see here as an ulcer. He also had other smaller lesions near the anus and on his skin disseminated, but not many. These became more papulopustular, and there was 2 on his face and abdomen and legs. So you can see that the time course is somewhat different. He actually had a positive sample from his blood as well as from the lesions. And this is possibly because he presented to us much more earlier than the other cases. And the final case is a 36-year-old man who is also HIV positive, but an elite controller, although on treatment with dolutegravir lamivudine. High CD4, undetectable viral load, and also sexually active and may have been in similar locations. I present this case because there were multiple points where he accessed health services along the way. And he began with fever and myalgias and malaise, and then developed symptoms of proctitis, followed by dissemination to cutaneous lesions. Those improved but he always had persistent rectal pain, at which time, and then these lesions healed. So he came to an STI clinic when he had the cutaneous lesions and received treatment, but all his STI testing was negative. Because he had continued rectal pain, he went to the emergency room, and there they consider the diagnosis of disseminated gonorrhea because of the skin lesions and the rectal ulcer, but all the testing was negative. He subsequently was seen in follow-up in an infectious disease clinic where chancroid was considered. And just to say that there already had been an alert for the last month or two in Montreal about possible cases of chancroid, which now in hindsight, we might have to go back and think about, as maybe these were earlier presentations of monkeypox. But nothing was positive at that point, and his symptoms didn't change with treatment. And finally, he was seen in the tropical medicine clinic where the monkeypox diagnosis was entertained and confirmed. So the key take-home points, I think, is that the presentation is not classic, and we need a high index of suspicion. It's quite variable, and the order and onset and the extent of dissemination and symptoms can be quite variable. What seems to be common in all these cases is that there was anal or genital lesions, and they were often quite painful, and they often had multiple points of contact with the health system, and the diagnosis was not entertained. So monkeypox in this setting could be masquerading as other sexually transmitted infections, but also was co-occurring with other sexually transmitted infections, such as rectal gonorrhea in one of the cases we saw. Sampling of the lesions had a very high diagnostic yield. Very few had positive blood DNA levels, and this may be because they were presenting late in their illness. And most of the cases were relatively mild and resolved spontaneously without specific treatment. But the time course was fairly long, if you noticed, in terms of the timing of the development. So this really speaks to the point that there's a big possibility for extended periods of infectivity because people were actually still out in the community during a long part of this illness. We have had other cases that have required brief hospitalizations because the symptoms were more severe, but thus far, no serious outcomes. I'm just briefly going to point to what samples to take, because this is one of the major things that came up for us at the beginning. I think first advice I would give is consult locally, because it can vary in your institution and in your setting about what's available for testing and where it needs to be sent and how they should be processed. And this is evolving very quickly over time. The other thing I should say, it's important to protect yourself as a healthcare worker, and that we are recommending a full PPE, similar to what you might wear for someone who's got COVID. That is N95 mask, eye protection, sterile gown, and gloves, which are disposable in the room. We are not isolating people necessarily unless they have respiratory symptoms in negative pressure rooms. They're just being seen in single rooms, but this may differ depending on your setting. We clearly cannot isolate all these people as they did in the 7 cases in the UK because we would quickly run out of place to do so. Ideal samples are blood for DNA, either an EDTA or serum tubes. A nasal swab, as you saw, there's quite early on particularly, but seems to be prolonged nasal oropharyngeal shedding. Tissue, either the roof or crust of a lesion or a punched biopsy if necessary, but probably not necessary. I would suggest that swabs are probably sufficient. These should be dry and put into a sterile container. Swabs of an ulcer, flocked dry swab in viral transport media. And the testing that's currently being done, we've now moved from before having to send everything to the central laboratory to a more screening PCR test, which is a pan-orthopox PCR, which is confirmed following with a simian orthopox PCR so that we can get rapid turnaround. And we're getting this, fortunately, because our public health department is so onto this within 24, maximum 48 hours. And I think time is really important here because we're trying to reduce the chance of onward transmission. So just to finish, I'd like to talk a little bit about treatment and vaccination, just to say this is a data-free zone at the moment. And so what I'm saying is really based on the very limited information we have to date in the literature. It appears that for the moment, most will have a mild self-limiting disease and will not require specific therapy to treat their symptoms. The question, of course, is, are there people for whom we need to be more concerned and may have a higher risk of poor outcomes? If we base ourselves on the historical information about monkeypox, I think we have to think about people who have either hemorrhagic disease, this is like what we might see with smallpox, confluent lesions, sepsis, obviously any end organ damage, encephalitis, or other conditions requiring hospitalizations probably should be considered for treatment. People who are quite immunocompromised, and I think, I mean, not necessarily people with HIV infection who are well controlled. We're talking about people who might be on immunotherapies or uncontrolled HIV infection. Pregnancy may be a risk factor, and young children. We don't understand the role of treatment to reduce viremia rapidly, but I think there's very intriguing that one of the cases that's presented in the Lancet paper I showed at the beginning used tocovirimat you can see that here on the right side of the slide. And this resulted in a very rapid reduction in shedding of monkeypox DNA and a resolution of symptoms that was quite quick. So this is very intriguing, given that it's an antiviral that's been approved for smallpox treatment and has some data in animal models that it can be effective. And I think at the moment, this is the drug that appears to be most promising. The role of vaccination is also unclear. There are vaccines available that were developed for smallpox, and the second sort of generation of vaccines that are attenuated, and it's listed here. It's an attenuated Vaccinia vaccine. Unfortunately, worldwide availability is relatively low, and these are typically controlled by governments because it was stockpiled in the event of need for smallpox. But ring vaccination of close contacts, ideally within 4 days of contact, to reduce secondary cases is being considered. And in fact, in Quebec at the moment, this is the approach that we've been taking. There was a case that received nosocomial transmission. In this case report, received the vaccine, but at 7 days, and it did not seem to prevent infection. So I think this is something that needs to be done quite early in contact if it's going to work. Whether we need to be vaccinating healthcare professionals who might be in contact with these cases is unclear as well. At the moment, the supplies are quite limited, and that's not being the approach that we've been taking, though that is a recommendation I've seen from other jurisdictions. There are other antivirals that may be active in vitro and in models, such as brincidofovir, but if we look at the report from the Lancet, where this was attempted in 3 cases, there may have been transient reductions in monkeypox DNA, but in all cases they had high levels of transaminitis that was dose limiting and had to be stopped. So this looks like it's less likely to be something to develop further. That said, it's hard to know, given that they were all given relatively late in the disease course, so maybe they may have activity in earlier times. And there's also some reports of using intravenous, or thoughts about using intravenous Vaccinia immune globulin if it's available early on as a prophylactic treatment. So I'm just going to conclude and just to remind us, I think the presentation is quite variable, and it can be quite subclinical to these more classic lesions that we've seen, and the period of symptoms is long, so the potential transmission, this presents a challenge for us for case recognition as well as for containment. And this is possibly why this may be been occurring under the radar for several weeks to a month or more before we recognized that it was in our city. The population that's currently experiencing the greatest burden may have concomitant STIs, and whether this alters the disease course or the presentation is unknown. In particular, the role of HIV infection remains unknown. If you notice, the predominant number of our cases did have HIV infection, but that may not be true in larger series. There's still many gaps in our understanding of the main modes of transmission that's driving the current outbreak, and whether there is actually true sexual transmission versus contact-to-contact transmission. As mentioned in the first talk, oral secretions and skin-to-skin contact are efficient ways of transmitting this virus. And of course, these occur during sexual acts. But the stigma that's related to this community is likely to impede the response. And I think we have to be very sensitive to that. And finally, the role of treatment and vaccination in managing infections and reducing the spread really needs to be urgently determined. So I'll just leave with this final thought, and the one that struck me in an article that I read in our CBC News recently. How did we get here, and why are we here again dealing with this outbreak on an urgent way and not so prepared? And I think it's because, unfortunately, again, monkeypox is a disease that has traditionally caused outbreaks in Africa, usually in very remote parts of Africa, and infecting populations that the world simply doesn't always care about. And if we don't take these things seriously for the people that they're affecting and learn from them, we're going to keep making mistakes. And I hope that we can do a better job this time with monkeypox. And I'm looking forward to Calista's talk at the end to help us guide us there. Thank you.
Thank you very much, Marina, for once again that excellent overview of clinical presentation, as well as the management pathways for those who you've been seeing in Quebec and other places. Moving on, as we heard from Meg, and as we've all learned from the COVID-19 experience, there's nothing like collaboration and sharing of data to advance both the clinical management as well as research in all these outbreaks that we've been experiencing in the last few years. So we have to speak on the importance of collaboration and networking, particularly in a fast-moving outbreak like this one. Dr. Chloe Orkin from Queen Mary University of London, who's also a member of our governing council. Chloe is going to describe the network that she and others have very quickly put together to see how we can best respond, both clinically and with research, to this latest infectious disease outbreak. Chloe, over to you.
Thank you so much, Adiba, and thank you for these absolutely wonderful talks that we've heard so far. Really, I've learned so much from them. In the interest of time, I can see that there are many, many questions, and they're clinical questions, and my talk is more about a call to arms. So I'll endeavor to be a bit faster to enable questions. But I think what I would like to talk about really, as Adiba says, is how can we learn from COVID? We're continually talking about how the world is never going to be the same place, and our interconnected world and all the lessons that we have learned. So I guess from my perspective, considering that this is clearly the largest outbreak outside of West or Central Africa, and that the pattern of what happened in COVID is that individual clinics and small groups of hospitals would start to publish case series, and this is indeed what's been happening. And we saw, as we saw this excellent paper that was referred to in both of the last talks on the UK outbreak in 2021 with 7 cases. And I won't go into it because it's already been very well summarized. With the knowledge as clinicians who are seeing cases that public health agencies and the WHO will soon respond with large data sets. The question is, in terms of what we did learn from the outbreak in Wuhan, is we saw that individual clinicians worked round the clock to describe the case presentations. And what we saw in these descriptions is that in many cases, they found some of the key associations and key points that actually informed our research response. They identified the effect of male gender, they identified cardiovascular concerns as risk factors, they identified the association to the seafood market, and they also described the clinical features extremely accurately, both within and outside of the lungs. And this was a paper that quickly described the risk to healthcare workers and showed, how quickly it could spread and identify that it could spread to young people. And both of these papers also identified important lab findings, such as the IL-6 blood test, which we can use to sort of monitor severity and response. So I just wanted to highlight how helpful these very early case studies were in informing everything that happened, both in terms of clinical management and in terms of subsequent research, in terms of long-term cohorts and in terms of interventions for people that were considered to be at high risk. But because of the fact that SARS-CoV-2 was so absolutely infectious, and because of the huge size of some of the hospitals in China, the numbers of cases that were able to be collected very quickly was actually very large. As I said, these were absolutely vital for informing both clinical care and research questions. So in a smaller outbreak situation, the case numbers are lower per site, but the need for a large case series based on clinical findings remains very acute. And so my view is that gathering data from an international group is very important to ensure that presentations are uniform globally. Even in a DNA virus, it's important to understand in terms of potential spread out of endemic areas. We know about the West African identification in terms of sequencing so far, but it is important to try and create a global picture as quickly as possible. So I guess with my IAS Governing Council hat, and my hat as a past chair of the British HIV Association and someone who really believes in clinician activism and empowering clinicians, individual clinicians who are at the coalface seeing patients with the ability to try and communicate with each other and to define what they're seeing and to develop these urgent clinical networks to try and find a way of contributing a larger case series where the numbers per hospital are likely to be smaller. So this was sort of my sense, and to try and collaborate rather than compete to share small case series and to really try and increase the numbers as a novel way of trying to amplify the voices of individual clinicians and empower them, and in some ways to try and democratize knowledge and how knowledge is acquired and shared in a situation like this. So with this in mind, we've created a rapid network to submit a case series consisting of uniformly collected data from individually consented people to describe the initial presentation, just that initial visit, and the clinical care provided, including STI tests and results, and whether people were admitted or treated. And the aim is to develop a rapid review paper with cases from multiple countries, both in and outside of the EU, and to try and create a new prototype for collaborative clinical response by engaging, and also to, at an early stage, engage community members to advise on a manuscript where there's enormous sensitivities in terms of how populations can be stigmatized, and to make sure that the messages that come through are very clear and carefully considered, and to also consider the advice that we've been receiving, through WHO briefings, such as the one I attended yesterday, around the utility of the images that are shown, and making sure that you try and show images which are early stage images to try and reduce the time to detect cases, so that this is what is really, really seen, both so as not to terrify people unnecessarily, but also to try and to do this in public health interest to reduce time to detection. And additionally, in addition to that work, I've also been working with my colleagues who are qualitative researchers at my university to develop a survey to look at perceptions in stigmatized groups, such as particularly in sort of Black populations and gay populations who feel particularly stigmatized by the public health and media messages, particularly the media messages that have come out, and to try and understand their perceptions of these messages through a survey. Yesterday, at the WHO briefing, I've been linked in with the social science group of the WHO, and I'm hoping to work with others to try to see if the survey can be adapted for broader use, in terms of use by sort of community groups. And this survey that's been developed, we developed, co-created with community groups in the UK who are very prominent in the response to monkeypox, particularly Prepster and Will Nutland, Sophia Forum in terms of women, and Sophie Strachan. So I think that that's some of the work that we've been involving ourselves in. And once again, I think that clinician activism is crucially important. And I feel very honored to have been able to link with many clinicians that I know very well through my own research networks, and to have been referred by word of mouth to other clinicians that I didn't know. And I'm delighted to be collaborating with Marina and others in this particular series. So I'll stop talking now and hand over to the next speaker.
Thanks very much, Chloe, and great job on the initiative that you've started. I think there's going to be a lot of interest for it, and hopefully there will be a lot of great outcomes coming from it as well. As we've all heard, it's really important that the messaging around this outbreak is handled well, and of course the involvement of people most at risk. And right from the beginning, Calypso Macofoni, who's also a governing council member, has been in touch with the community in terms of the appropriate response to this outbreak. And Calypso will be sharing with us on his views on the priorities in responding to monkeypox amongst gay, bisexual, and other men who have sex with men. Just very briefly, apart from being our governing council member, Calypso also recently, congratulations, gained his PhD in social epidemiology at Harvard University, and had the, maybe not so recently, but had the event just a couple of days ago, I think, and is on the WHO Scientific and Technical Advisory Committee on HIV and viral hepatitis, amongst many other roles that he plays. So Calypso, over to you.
Thank you, Adiba. I am going to give a bit of an overview of kind of how I have experienced how people talk about these outbreaks and the kinds of responses that are being mounted. So I should start by saying I'm in New York City. At the moment, there are 4 cases that have been identified and confirmed, 21 in the US. So the numbers sound really low here. But we don't think that in a city the size of New York, there's 4 of anything. So we are also concerned that there's a fair amount of subclinical infection that we have yet to discover. And the question is, how widespread is it and how long has it been going on? There have not been any identified cases in Africa yet outside of the endemic countries, as far as I know, and specifically not among gay and bisexual men. This does not mean that a similar kind of pattern of outbreaks isn't happening in the region. It just means that we haven't detected it yet. In fact, I think it would be interesting to, if it wasn't happening, it would be interesting to find out why. And if it's happening, then it's important to respond to it. So I think it's important to kind of keep in mind that just because the cases that we're really discussing and that have raised alarm happen outside of the region, it doesn't mean that a similar thing isn't happening in the region. These aren't the first kind of outbreaks of human-to-human transmission. Since about 2017, I think there have been outbreaks in Nigeria, and there have been travel-linked cases outside of Africa, which have largely been contained. But in this current outbreak, most of the cases have been detected among gay and bisexual men in European cities and linked with gatherings, parties, and particularly parties where sex happens. In the media, there have been some cases in some regions of vilifying gay and bisexual men, but by and large, I think in the US, journalists and commentators have been kind of careful in how they talk about the monkeypox outbreaks. Online discussion, on the other hand, has already started showing homophobia, veiled as concern about public sex or concern about anal sex. But the fact that most cases are among gay and bisexual men, I think, has not gone unnoticed by the public. And part of the homophobia, I think, shows up in how people are thinking about this as a sexually transmitted disease or a disease that gay people are specifically susceptible to, because most people, I guess, think that all gay people do with each other is have sex. But the association with gay people, I think, is kind of an important part of the storytelling around monkeypox. In the US, I think government agencies have been really proactive in connecting with activists and setting up lines of communication. And I would have to say that we have to be careful about who's in the room and who's not in this phase of the response generally, not just in the US, but globally. I think what's happening is that people who are already connected to these institutions, like me, I've been connected with the WHO for years. We are the first ones to kind of come to the conversation. And I think it's important to be very careful about understanding who's not in the conversation. So in the US, the government has tried to reassure everyone that testing is going on, but there's some disagreement. You know, we wrote an op-ed in the New York Times. I wrote one with two activist friends of mine where by that stage that we wrote, which was last week, Saturday, there had been like less than 20 tests that had been run at the CDC. The government has sounded open to engaging and learning, though, from activists and from the AIDS experience, the very first. It's interesting because some of the people who were around in government agencies for the very first AIDS outbreaks in the US are the people who are now thinking about this outbreak. And I think the COVID experience has also really shaped how we're acting now and the kind of urgency that we're taking. There are now new attempts to coordinate and do some investigation of the outbreaks by, for instance, using leftover blood samples and using samples that have been banked from large cohorts of men who have sex with men to assay them and try to understand when the outbreak started in the US versus when it's been detected in clinics. And then as far as activists have been going, it's been difficult to assess how urgently to intervene. There isn't a lot of information about what kinds of interventions are necessary and would work. For example, we're at the beginning of Pride season in the Northern Hemisphere, at least in Western Europe and North America. And it's not clear yet that it's time to try to halt sex parties, try to halt Pride events for the purpose of containing the outbreaks. But there is also not a lot of assurance that if we try to do that, it would work, or whether it would move people to private settings where they would be having sex with other people, but without the benefit of an institution that is connected to the public health apparatus. And at this point, a lot of sex venues have been reaching out to activists to try and understand how to advise their clientele, to try and understand how to go forward with their planning, what they can do to mitigate the risk. So it's a difficult situation because on the one hand, it's important to be absolutely clear about how these outbreaks are associated with gatherings of gay men associated with sex, at least in Europe, and we suspect the same thing will happen in the US. But at the same time, it's important not to alienate and lose the people who are actually in contact with gay men who are not in public health, gay and bisexual men who are not in public health. And I've personally found it really difficult to talk about these outbreaks because on the one hand, we have, as activists, we kind of are very attuned to situations in which the ideas we use to think about the HIV epidemic or this epidemic, we're very attuned to how those ideas can be dangerous and can lead to violence. So on the one hand, I think we're thinking carefully about how to talk about these outbreaks without associating them with gay men in an essential way. In other words, without associating, without talking about these infections as if they are gay infections, but at the same time, it's important to respond because gay and bisexual men are probably going to be the first population to be really hit hard in the US once the numbers increase, which I think they are likely to. And once again, I think it's important to kind of acknowledge that it's Pride season. So people are traveling to bigger cities, between bigger cities and where they live, possibly interregional travel across the Atlantic. And they're traveling to come to big events in the summer after a very difficult few years with COVID. So I think there'll be a lot of in-person close contact going on, including sexually, but not limited to sex. In terms of priorities, I would say there are three that have really come out. One is kind of messaging, how we talk about monkeypox. The other is testing. And the third is vaccination and what kind of strategy to use with vaccines. In terms of messaging, from the outset, I think there's been a consensus from the WHO to community-based organizations to state agencies or US government agencies that are responsible for public health in some way. There's been a consensus that we have to get the messaging right. So a lot of the focus has been about constructing accurate and accessible messages, accurate with respect to the information that we have at hand. And we don't have a lot of information at hand. So some of the awkwardness has been, well, how do we talk about the idea that this could be transmitted through respiratory droplets, fomites, through skin-to-skin contact, particularly through sex? How do we communicate about all that without being alarmist, and acknowledging that as more cases develop and as there's more description of these cases, we'll have clearer ideas of, epidemiologically speaking, what are the modes of transmission that are really important, that are really driving these outbreaks, and which are theoretically possible but are not kind of central to the epidemic as it's unfolding now. Community-based organizations have begun to create their own messages, pamphlets and such. And by and large, they agree on the content. I think soon there will be a need to really think about how to coordinate across different groups that are creating these messages so that we have consistent messaging, so that people are not confused about what is, how does it get transmitted? What are you going to see in your body as the disease process unfolds? And this is kind of important in this particular historical moment because of how COVID has, because of how misinformation has really stirred up around COVID, because of how there are conspiracy theories that circulate that are taken seriously by lots of people about kind of the manufacture of the COVID pandemic. And so I think I have a sense of fear that if we are not consistent with our messaging and if we're not clear that it's going to change, then we risk having the same kind of misinformation take hold with respect to this epidemic. And there have been some concerns. I think they're changing, but the clinicians will know better that the images that we see are not images that would help us to identify smallpox infection, especially early smallpox infection when it happens to our bodies. So that's both in terms of the presentations that we're seeing in these outbreaks and in terms of just having a diversity of skin tones presented so that you can see it when it happens on your own skin. There's also been a lot of discussion about creating messages for different constituents. So messages for like institutions like venues, sex venues, parties, clubs, messages for NGOs and CBOs about how to talk to their own constituents about monkeypox. So kind of on all fronts, messaging is kind of very important at this time. The second thing has been testing. It's been urgent in the US to improve testing because of the COVID experience of not having enough tests to really go around and allow people to have control of their health by understanding whether or not they are infected with this microbe and understanding how to behave in response to that information. So some specific problems in the US that have been under discussions are that testing is centralized. So in order to confirm a monkeypox case, the sample has to get to the CDC labs in Atlanta, whereas kind of closer to where people are, a more general test for the orthopox virus can be conducted. So the process of doing the orthopox test, sending the sample to Atlanta, waiting to hear back, takes a long time, and is one that possibly doesn't have the ability to increase capacity quickly, which is what we might need once numbers start climbing exponentially. There have also been concerns about the ability, the regulatory framework for testing. So in the US, particularly the ability for private labs to devise tests and use them without the regulators coming in and saying, you know, you haven't gone through these long processes for having your tests approved. And finally, with testing, I think there's a concern that the public health measures that that testing kicks off are also important to consider. So if I go and I have a rash and I go to my provider and say, I think this rash might be monkeypox, if at that moment I'm put in isolation, then I think it will prevent people from coming forward and presenting with concerns about monkeypox. So we have to be very careful to take public health measures that do protect people from onward transmission, but that also do not impose such a burden that it disincentivizes people from coming forward when they think they might have monkeypox. And then finally, with respect to vaccine, as we've heard, there are vaccines that are available to prevent infection, and there are questions about the safety profiles of the different kinds of vaccines and how much and the availability of them, and an effort to make sure that we deploy those vaccines as efficiently as possible. Right now, I think the kind of default strategy is something like a ring vaccination, where you vaccinate the close contacts of confirmed cases. But we also don't know how widespread infections are. So that strategy might not work, for example, if there's already wide dissemination of monkeypox in the population. Ring vaccination won't slow transmission down. So then the question is, with limited vaccine supply, what kind of strategies can we take deploying the limited vaccine in a way that maximizes impact in the population? And so related to that, we are in the early stages of coming up with a community-based study in New York City that would map out the sexual and social networks safely without collecting personal information, in order to figure out how to intervene in the network among the people who say are the most connected across the city, who, if you vaccinate them first, you break up the city into different pockets, which are then easier to deal with, rather than having this one connected city through which transmission can happen fairly quickly, especially coming into Pride season. So it's really important at the moment for us to try and figure out how we're going to use limited supplies of vaccine. I think I'll stop there and look forward to discussing with everyone.
Thank you so much, Kaletso, for really outlining efforts currently being taken by yourself and the community to balance the, sensitive issues around messaging, to increase awareness and yet not stigmatize those at risk. It is a very difficult balancing act indeed, and especially given that all these large gatherings that are going to take place with Pride. We have about 10 minutes or so, and there's a whole host of questions that, as I said, came in even before the webinar started. I'm just going to try and someone's asking if we can extend the Q&A for 10 more minutes. I am happy to do so. I don't know about the other speakers. Now let's try and get through some of the questions that have, I think, been recurrent. And I think one would be in the area of possible transmission. And of course, knowing we don't have enough data, but from historical cases, as well as what we know now, if we could have a bit more discussion around what we think are the most dominant mode of transmission. There have been concerns about airborne, again, unfortunately. And so because this has real implications, of course, in terms of public health measures. So there have been some discussions around the role of saliva as well. So who would like to take this question? Marina or Chloe or even Meg?
And maybe Megan can also, she may have more. I think just to say, there's a missing, we just don't have sufficient data to be sure about a lot of these things. And I think we have to extrapolate from what's been reported in the past and where we know we can detect monkeypox DNA. And so I think, so starting from the top down, I guess, the respiratory issue, it's one that's not felt to be spread by aerosols. At this moment, we have no evidence that that's the case. But we have to be cautious of everything we say and not be dogmatic, because we also said that at the beginning of COVID-19. And clearly in certain circumstances where there's very high levels of viremia, for example, very high respiratory secretions. So in our setting, if someone is presenting with respiratory symptoms and suggested monkeypox infection, we would isolate that person in a negative pressure room and take precautions. But in general, we do not think aerosolization is going to be a major route of transmission. Therefore, it's not very likely, and we have no evidence that it's spreading in that way right now. So droplets, though, yes, and that would mean including potentially in saliva, because it's in and found in the oral secretions. And this may be one of the ways it is, quote, sexually transmitted, because people exchange bodily fluids both from the mouth and other parts during sexual encounters. So definitely, and we saw this prolonged level of detection of monkeypox DNA in the case series from the Lancet. That said, is it always infectious even when you detect the DNA? And we don't know at what stage of the illness it continues to be infectious. And these are important research questions. Whether it's transmitted definitely through skin to skin contact, lesion to lesion contact, I think that's probably the principal way that things are happening at the moment. But the importance of fomites, I think we talked about that. We know smallpox was, one of the major ways it was spread was through contaminated clothing, bed sheets, linens. This can happen with monkeypox, and so this is something we have to be concerned about. So whether or not environmental services are important or not, I think is something that's urgently needed to discover, but we have to assume that yes, these are DNA viruses. They survive outside the human body much longer than RNA viruses, and so they can be detected in the environment for prolonged periods of time. And then finally, as of now, as far as I know, there's no evidence that monkeypox has been detected in semen, but there's no reported cases of it. It doesn't mean that it's just not been studied. So whether this is, as we've been seeing with other viral infections such as Zika virus and others, where there's actually a component of potential for sexual transmission is unknown. And I think we have to urgently determine that. I don't know if Megan wants to add anything to that.
Thank you. Meg, did you want to?
I think you covered it really well, and I think these are the critical questions around transmission that has to be identified, and that's why we're having this scientific meeting happening, bringing people together around some of these urgent questions. We do, and we do know as well that it can be transmitted from mother to infant as well, and so those are cases that are well identified in DRC and other places of the world. So I don't want to make anybody very worried, but these are definitely some of the issues that we have to identify now and develop a plan in terms of protecting oneself and protecting the healthcare workers and mother-child. And when our clinical guidelines are put online, there will be quite a bit of guidance around PPE or personal protective equipment, as well as infection control. And I recommend that you take a look at that as well as we move forward. Thanks.
Thank you. Thank you for that, Nick. There was an earlier question, since you've got the mic now, around, you touched a little bit on concerns with HIV co-infection. So if you could expand a little bit on that, on what we know and what we need to know further. Mm-hmm.
Well, I think this is again an area where there's just a little bit of research, a little bit of data, and as Chloe was mentioning, we have some small case series. Most of those right now coming out of Nigeria, but I think we need to have more data as we go forward, especially in the outbreak that we're seeing here. All that we do know is that those who are in those small case series in Nigeria, those who were untreated fared worse, meaning untreated for HIV fared worse. But currently right now, if somebody is immunosuppressed, meaning that either from cancer drugs or from HIV, there is some evidence for prolonged viral shedding, prolonged infection. But I think I just want to say we need to know more. And this co-infection with other STIs. So it's an important, and I would reiterate the comment that Marina made, is that identifying early, having more photos so that clinicians have a high suspicion, testing for other STIs, ruling those out or co-treating if needed. And it might be a good time to also ensure that, that HIV testing is happening, that antiretrovirals are maintained if somebody has been on treatment. And I would suggest that we should be doing more of this research as we move forward. Looking forward to having those answers very soon.
Thank you. There have also been some questions around diagnostic testings. We're currently relying on PCR, and even in the US, Pletso, you mentioned that it has to be sent to Atlanta. Do any of you know if there are efforts to have more, accessible form of testing?
I mean, I'll go ahead. Maybe Megan has more information on this worldwide.
Well, I think this is definitely something where we have in the response to this outbreak, there is a diagnostic group is working on what will be the possibilities of expanding and working with the manufacturers to expand. And there are a few at least one manufacturer and maybe others who are interested in developing these more rapid and real-time diagnostics. How far that has gotten, I'm not going to be able to give you. They're speaking about this as we sit here right now. But Marina, you may have some more information from Canada. But it's definitely high on the priority list in trying to get the public sector, the private sector to work together to see if we can rapidly get forward with more simplified testing approaches. Thanks.
I mean, I think just to mention the issue, I mean, and it relates back to COVID-19, we really recognize how important it is to have rapid and sensitive and specific diagnostic tests. And these are always a challenge because as much as we want them, they're not always available. We've reflexed to something similar where we just do a pan-orthopox PCR at our local public health lab. So at least that cuts down the time and the shipping and the turnaround, and then it's confirmed by a simian orthopox specific assay in the central lab. But as there are more cases develop, this is going to have to be decentralized. There's no question that the volume won't be, be able to be handled, and timely diagnosis is really crucial, I think, if we're going to make inroads into isolation and containment. I think Chloe.
And what we do have is we have serological testing right now, as well as the PCR, but a rapid diagnostic we don't have on our fingertips right now. Pardon me, Chloe.
No, that's fine. I mean, I wanted to pick up a little bit on the HIV points, if that's okay, firstly. And just to say firstly that I absolutely support the comments on the issue of the aerosolized transmission point. And I think that it's crucial now that we are honest when we don't know, and we say very clearly that we don't know when we don't know. And I think I so reiterate that point because I think if we learned anything from COVID, it's got to be that. In terms of HIV, yes, I think that my reading of the cases is that there were, of the 7 deaths that were reported in Nigeria, and 4 of them were in people with HIV, but they weren't controlled on treatment. And then in the other series that was presented, I think by Meg and by Marina, also from Nigeria, out of 41 cases, I think 9 were living with HIV, and these were hospitalized patients. So they seem to have, so almost like a quarter of those people who were hospitalized were living with HIV. Once again, not a huge amount of detail about treatment, most of them seemingly not entirely controlled. So I think it's very important not to be alarmist about the messages. What I would say in this case series that we're developing, a large proportion are living with HIV. And also there's quite a variety of sampling methods and also what is being sampled. People are sampling from different places. So I think that's going to be quite interesting.
Chloe, whilst you're on with the mic, Simon Collins has mentioned several times in the chat the importance, and you too, Calypso, and mentioned the importance of having good high resolution pictures, as part of the educational campaign, as well as, to destigmatize the disease. Is part of your network, the network that you've created, are you also asking for specifics? Yeah.
Yes, we are, particularly interesting images that look unusual. But I think, like, for example, one of the difficulties is somebody has got an unwell person with HIV who isn't on treatment, who's quite unwell. And this person is in isolation, and it's difficult, to bring the camera in with the barrier nursing. So it's quite difficult for that person to actually get an image. So it's not always as easy as you think. And then also, with the imaging, the level of consent and clarity around the use of the image has got to be at a different level to what is, I believe, to what is required, to be included in a very de-identified large case series, the level of understanding of the person in terms of providing the image. So I think that's another challenge. So we're trying to grapple with that in terms of the communication with people, asking people to provide images, but making very clear that if they do, we need to be very clear on how this has been obtained. And I guess some people are able to get medical illustration in to take a good image, and then in some situations, it's not like that. So I take your point on board.
Okay. Thank you. In the remaining time we have, I think, if we could speak a little bit more on the issue around vaccination, who to vaccinate, what exactly do we mean by ring vaccination, and the role of human immunoglobulin and such like. Anyone?
A few of it, the immunoglobulin question, at least, there's no data at all. So it's theoretical and probably has a limited role, especially because the availability is very limited. Where it might be important would be in someone who's got a recognized deficiency, either hypogammaglobulinemia or T-cell deficiency, where they might be able to benefit. B-cell deficiency, where they might be able to benefit in the way we would use it, say, for example, monoclonals for COVID. But really, I think it's going to have a very limited role. I think there's much more promise for antivirals, and the vaccination issue is complicated really by what we'd love to do if we had a vaccine available, freely accessible for everyone, and what we have to do practically in the current situation, which is of limited vaccine supply. And I think Megan probably can talk much more to that in terms of the global layer, but locally, we even in Canada have limited supply. And so it's being directed by the national decision makers and our local public health. And we've approached a ring vaccination approach, which is, just as Calista mentioned, identifying a case and their contacts, vaccinating the contacts within 4 days of the contact, because it probably doesn't have much use beyond that, and possibly also vaccinating the contacts of the contacts if we can find them.
Yeah, and we don't know the role of asymptomatic infection, right?
Exactly.
But yeah. And Meg, did you want to add anything about the vaccine?
Well, just to say that we can say that there's 85% say protection from the smallpox vaccine. So people in their late 40s, 50s may have some protection, but we don't know how long lasting that would be from their previous smallpox vaccination. But it's exactly as Marina was saying, who to vaccinate and when to vaccinate, and to use the current limited stock of the second generation vaccines is under discussion right now. So I think taking an approach where those who are at greatest risk contacts, as well as people. It's being used as well as PEP potentially, post an exposure, as well as for healthcare workers, laboratorians. I think those are going to be the critical populations and people to think about for vaccination. Globally right now, it's not going to be, nobody is thinking right now of a mass vaccination or a vaccination of all population. So it's very different in terms of the amount of work and thinking that has gone into, say, COVID, where it was trying to get everybody in the world, or at least 70% of the world, vaccinated within a period of time. But so those conversations are happening right now, and I don't want to jumpstart and say what WHO will say when we haven't come out yet, but look forward, and we'll be happy to share with IAS as soon as those recommendations do come out. We'll share them with you so that you can share with this audience. Thanks.
Thank you so much. And in the remaining few minutes, Calypso, perhaps I can invite you to share sort of your advice to community groups on how and what are the key things they should be doing to educate their communities on this monkeypox. I mean, you gave us, what the big picture, but some key things for them to take home.
Yeah, so I think more broadly, I think that along with diagnostics, therapy, and vaccination, we really have to understand the systems that are going to be used to deliver these interventions and prepare those systems. If you can't deliver PrEP to Black men in the US South, how are you going to deliver a vaccine? How are you going to deliver therapy? How are they going to even be tested if they don't have access to healthcare services, or if it's so stigmatizing that they'd rather not attend? So those systems questions that we already have in HIV are here with us in monkeypox, except that we have an opportunity to stop monkeypox from becoming globally endemic right now. So we have to, so there's some urgency around developing those systems. And then I think the second thing, which is general as a social epidemiologist, is that we have to anticipate that once enough people are infected, that social gradients will start to show up. So people who are more marginalized will be more susceptible, will have worse treatment outcomes because of very many different reasons, because of the resources they have available, because of their ability to take on information like from this webinar and apply it to their lives quickly. Because if you say bedding is a format that is really important for transmission, and people who live in settings where 3, 4, 5 people share a bedroom won't have the ability to do much about it. So we have to be able to anticipate that it's going to form patterns that we see with other illnesses. We also have to anticipate that it's going to move populations. And so we can't get caught up in only showing pictures and messages for gay and bisexual men, because when it moves, then we will not be ready to attend to where it is and how it's spreading. For community-based organizations specifically, I would say it's important at this point to try and coordinate on messages about the illness itself and about how to respond, and to coordinate so that there isn't panic, but that people are ready to act. So people are aware that, oh, it might happen that in 3-4 weeks, we have a week where we close sex venues. I don't know, that's an extreme measure that I don't know if it would work, but it's an example of something we need to be prepared for. Just like with COVID, there was kind of announcement about the possibility of stay-at-home orders before stay-at-home orders actually came. So I think we need that kind of forewarning about what we might have to do to contain these outbreaks.
Thank you for that. We are about 10 minutes over time, and really I want to thank all of you for attending, and I'm sure you've all agreed with me that it's been an excellent presentation from our panelists who have been roped in at the very last minute, and I thank them very much for agreeing and for putting on wonderful presentations. From the IAS, this is not going to be the last sort of webinar on this topic, which we feel is very, very important. As you know, we're also hosting the AIDS 2022 in Montreal in July, end of July, and we have reserved a session on monkeypox. So for those of you who are planning to come, either in person or virtually, we will be having a session on monkeypox. So once again, thank you very, very much for attending. And I apologize for not being able to answer each and every one of your questions, but do send them along and we'll do our best to respond. And we will be sharing the slides with you at a later stage when we have consent from the relevant people. So good night. Good night. It is from me, from Kuala Lumpur, and have a good day the rest